Okay. Here we go. Should be coming up now. We shall see. Assuming technology is working with us today. It's trying. It is trying. Come on. It's really trying. I'm going to give it another second here. I'm getting the spinning wheel of death here. All right. I don't know if you guys can hear me, but my screen is frozen. There we go. Hold on. I'm going to try one more time. Oh, you see it, huh? Well, I just undid it. Let's try again. My screen froze on my end. Let's try one more time.
I see
Okay,
it.
good. I do too now. Awesome. We're all here. Okay, shoulders and arms and all that good stuff. Yeah. Okay. By the way, Mr. Singletary, I think you talked about the Teres Major and Minor and all that stuff and them arguing with each other. Look at this picture right here. This is the Teres Major and this is the Teres Minor. If you guys notice, the Teres Minor goes and hooks on the back side of the arm. This major goes underneath and disappears, and that's because it's going underneath the arm to attach to the front of the shoulder. And that's why it's so different. They both start at roughly the same place, but one goes underneath the shoulder to attach in front, this other one attaches behind. Mr. Singletary, yes, sir?
Okay, so they just happen to be sitting next to each other, and that's it.
Yeah.
They don't agree at all.
They don't agree at all, yeah. They're right next to each other, and that's probably how they got named that, but they actually do very different things, and they go to different locations. You know, so it'd just be like you and I living in the same house, but you go to Flagstaff and I go to Tucson, you know. We're related because we're in the same house, but we don't do the same stuff. Yeah. Okay. So take note of this, everybody. This is the edge of the scapula. Anybody know what's the official name for this edge of the scapula? Miss Clayton, please.
The medial border or the medial edge of the scapula.
Perfect, exactly. The medial border of the scapula. Awesome, awesome, awesome. Okay, so the medial border of the scapula is something we're going to be focusing on a lot today because there are actually a lot of muscles that attach to that. If you start out at the inferior angle of the scapula, and you can actually do this on a lab partner, you can grab their scapula here. As you move up, you will touch the rhomboids major, you will touch the rhomboids minor, and it's hard to see in this picture, but if you keep going up, you'll get to a muscle on the medial border of the scapula, right up here by the superior angle of the scapula, that's called the levator scapula. This is the levator scapula. We'll look at a better picture in a second. But so, in a way, that's three muscles on the back side here. Rhomboids major, rhomboids minor, and levator scapula. You cannot see it, but attached to this medial border underneath the scapula on the other side, but attached to the medial border, is the Serratus Anterior. And we're going to learn about all these muscles today. So, you've actually got four muscles attached to the medial border of the scapula. Ms. Clayton, you have your hand raised.
Sorry.
Okay, that's okay. Mr. Singletary, you have your hand raised.
Okay, so the medial border is the white section that you're pointing to.
Yep.
And behind the rhomboid area. Okay.
Yep. That's the edge of the scapula that we're all used to seeing. It's this thing right here. This is the medial border of the scapula. This would be rhomboids major, rhomboids minor, levator scapula. But on the back side to that same medial border, there's a muscle attached to this whole area right here called the Serratus Anterior. And you will see pictures of them. But just to let you know, that medial border is a really important border to all of us because there are four very important muscles that attach there and have a lot to do with shoulder tension. All right, let's go find out about these muscles individually. Yes. And by the way, this is the Serratus Anterior poking out in front because it attaches to your ribs, but I'll show you pictures of that too. as we get closer. We are also going to learn about the Pectoralis Minor today. Pectoralis Minor and Pectoralis Major are very much like Teres Major and Minor. They don't really have anything to do with each other. I don't mean nothing. They work together sometimes, but they do very, very different things. So that's Pectoralis Minor. We're going to learn about that too, because Pectoralis Minor actually inserts onto your scapula and hooks your scapula into your ribs. All of these muscles hook your scapula into your thoracic region. So let's look at them individually so they make a little bit more sense, and then we'll put them back together, so to speak. All right. Miss Carrillo, please.
When you said it hooked onto your scapula and to the ribs, is that what helps also bring it around because you're contracting?
Yes, it is. It is a muscle that, along with the Serratus Anterior, helps you to protract or abduct your scapula, your scapulothoracic joint. Yes, you're absolutely right. That's exactly what it does. And because it's pointing down a little bit, it would also, what do we call it when things go down?
Inferior?
Inferior is below. Don't make that face. That was pretty good. But what do we call a downward movement? Miss Savarino?
Depression?
Depression, yeah. So so anything that goes diagonal, you're right, it's going to do two things at once away, and it brings it forward, yes, but it also brings it down. Yeah, good job. All right, everybody, let's look at the rhomboids, though. Some people call the rhomboids, by the way, the Christmas tree of the back, because they kind of go at this little angle, and if you see them on both sides, it looks a little bit like a Christmas tree, like a cartoon Christmas tree. And you've got rhomboids major and minor, and they both have the exact same actions. These guys do work together. They really should just be called the rhomboids, and they are sometimes. Because they go diagonal, right? They can do a couple of things. They definitely can pull my scapula back towards my spine. Can we see that? That if those muscles contract, the medial border of the scapula is going to get closer to the spine, right? I hope. And that is called an abduction or retraction of the scapulothoracic joint, right? They're going to pull it back towards the spine. Yeah? But because they go up at an angle, they can help in elevation as well. Yes, Miss Everson, please.
So is that a medial abduction?
All adductions are medial.
Okay.
So let me explain that better. Adduction means you are bringing something from the sides back to the midline. These scapulars are coming from the side back to the midline. That's all adductions. All adductions happen out here. You're thinking of medial and lateral rotations. And those tend to not go anywhere. They just roll in or roll out. But they don't get closer to the midline or further away. They just roll. Does that help? Kind of, sort of. Okay. Miss Carrillo, please.
Since they do the same thing, does that make them synergists?
Yes, absolutely. And I'm sure your brain, I know your brain has the power to not fire them both together, but it probably usually does. Probably usually uses them together. They are very much synergists. From a massage therapist point of view, they're the rhomboids. We don't usually distinguish between the two because they're both in the same spot. I can't even tell when I'm going from rhomboids major to minor with my hand. You know, it's a really weird distinction they're making. And that you're right, they do the same thing. They really do. So, because they go at an angle though, we can see that when they contract, they could lift up and in, and we call that elevating and adducting, up and in. They don't have to go up and in. Your body can stop some of those movements with other muscles. They could just do one or the other. But if we left them alone, they'd go up and in. And also, because they kind of grab on, especially the rhomboids major, by the way, because they grab on here at this bottom part, if they were to contract, they could also create a downward rotation of your shoulder. All right? That one's not as important to me, but it is important to moving your body around and stuff. So they could create a downward rotation because they pull on the bottom and lift it up. And when you pull on the bottom of a wheel and lift it up, the top goes down. And we measure rotations by the acromion process. So if I pull on the bottom, the acromion process goes down. Cool. I kind of remember these origins and insertions by remembering that the major actually attaches to 4 spinous processes of your back, and the minor attaches to 2. It's half the size. So the major attaches to T1, T2, T3, T4, T5. T2, T3, T4, T5. 4 spots. And the minor actually attaches to C7 and T1. Now let me explain what all those T's and C's mean and all that kind of stuff, right? How many cervical vertebrae do we have? Miss Rader, please.
7.
Good. So the first one is called C1, C2, C3, C4, C5, C6, C7. Who can tell me the next vertebrae inferior underneath C7? Miss Hendrickson.
Is it T1?
It is. We start over again. So this is C1, T2, C7, and then it goes T1, right? T2 all the way down to T12, and then what's the next vertebrae under T12? Miss Savarino.
So like your sacrum, like your SI joints?
No, you left out something between T12 and your sacrum. You left out 5 things between T12 and your sacrum.
Then I don't know, I apologize.
Don't apologize. Thank you. We'll take it. Miss Hendrickson.
L1 through 5.
L1, yeah, so T12, L1, and then Miss Savarino's right. Then after L5, you get to the sacrum. Yeah, I just wanted to kind of explain the numbering. So the rhomboids start, like, if you want to start from the top here, your rhomboid minor is on C7 and T1. And then the rhomboid major is on T2, T3, T4, T5. Right? So the rhomboid major attaches to 4 spinous processes. The rhomboid minor attaches to 2. It's half the size. Literally is. And they both go over to the medial border of the scapula. And they describe this, how they attach, by describing that the rhomboid major attaches to the medial border of the scapula between the inferior angle and where the spine of the scapula is. Basically. And rhomboid minor attaches to the medial border of the scapula right across from the spine of the scapula. But they hook your spine, which is your thoracic region in this case, to your scapula, and they essentially can retract, adduct, downwardly rotate, and even help with elevations because they run diagonal. And they are often called the Christmas tree muscle in the back because if you look at both sides like this, they'll look like a little Christmas tree. They are deep to the traps. And they are synergists of one another. Is there another muscle that we've learned about that can be a synergist with these guys? Miss Clayton?
Is it the lats?
No. Lats.
Oh, the Spinalis, the erectors. No,
No.
I'm not answers.
Thank you. I appreciate you trying. Miss Carrillo.
Oh gosh, is it the trapezius?
Well, does the trapezius adduct the scapula?
Did you say ad or ab?
Adduct, adduct.
Yes.
Yes. Does it elevate the scapula?
I think so.
Absolutely, ma'am. Your answer is 100% correct. I just was just kind of running through why. Yeah,
Thank you.
it attaches back there, and these muscles run deep to the trapezius, everybody. These muscles run deep to the trapezius. So when you're rubbing somebody's back, you're probably hitting their trapezius first. These muscles are underneath it, but you're rubbing them through the trapezius. It works. And you won't go a day in your life without hearing somebody mention the rhomboids if you're a massage therapist. It's always like tight rhomboids, tight rhomboids, tight rhomboids. I think massage therapists say that in their sleep. Tight rhomboids. Yeah, you'll just hear it all the time. Miss Dimitri, please.
In the book they have
bilaterally and unilaterally. So what exactly does that mean?
Yeah, with the rhomboids, it's not as important, but what it means is bi means 2 and uni means 1. And what they're saying is, let's take the trapezius, for example, because that one's really helpful, okay? Let's look at the upper fibers of the trapezius. I'm trying to make them with my little, I'll stop sharing here for just a second. It's a really good question. It's really important to understand muscles. I've got a little fake trapezius here, right? Upper trapezius, that's all I'm doing right here. Bilateral means both sides working together. Well, if both sides work together, my shoulders come up, right? Unilateral, one shoulder could come up or my head could come over. Now my head can't come over on bilateral because they're pulling my head both ways. So my shoulders have to come up. But unilateral, my head could come over. And that's what they're saying. They're just saying, are both sides working together or one side working only? And with muscles like that, it matters. Like your trapezius, it matters because it could affect the way your neck works. Both sides are going to pull your head evenly, so it's going to lift your shoulders. One side could lift your shoulder or pull your neck over. Does that make sense? Okay, and that's unilateral, bilateral. Just one side, it really means one-sided or both-sided. Are both sides working or one side working? It is a unicycle or a bicycle. All right. Let's go back to the good old rhomboids. Actually, let's stop there and take our break before we get into the next muscle. Let's do that. So I'll see you guys back at 9:41. 9:41. Thank you. Okay, everybody. Welcome back. When we last left you, we were discussing the rhomboids, the Christmas tree of the back. Let's get back to that. Ms. Carrillo, please. Hold on.
I'm on my iPad now. Want to make sure my head from the
I think you're asking if I can hear you, and I can, but you're cutting. Well, you're
Okay.
cutting out. But what's weird is my computer was not doing the right thing either. Okay.
Yeah, I was asking if you could hear me because I switched over to my iPad.
Yeah, I can hear you. We're good. It came through.
Confirmed. Thank you, Ms. Reader and Mr. Bose.
All right, I'm going to try to share again. I don't know what the problem is with this thing. Let's see. My computer's having a rough time. All right, there we go, finally. Okay, so we just learned about, or we've just been exposed to the rhomboids. The rhomboids as a group run from C7 for their origin down to T5, and they go over to the medial border of the scapula. And therefore, when they contract, they pull the scapula closer to the spine, which is called an adduction. Because they kind of go uphill, they can also elevate the scapula a little bit. And because they grab onto lower portions of that medial border, they can actually cause a downward rotation of the acromion process. That part goes down. Okay, if we move up this medial border further, we've already gone through, by the way, if you kind of grab your hand here, rhomboid, and you'd actually grab this on somebody, rhomboid major, and then we keep going up, rhomboid minor. There's another muscle up here. And that muscle, by the way, look how as a group they look like the same thing. Yes, Ms. Carrillo.
Yeah, I just wanted to clarify, when it's pulled closer to the spine, that's the abduction? Because it's in the back?
No, when it gets close to the midline, it doesn't matter if it's in the back or the front, when it gets closer to the midline, you are adding it back to the body.
All right, that's what I thought. I just wanted to make sure.
Yeah, and so
I'm getting confused with the lateral.
Yeah.
I'm talking about lateral. That's what
It is confusing. All this stuff is super confusing. But anyway, you are adding it back to the midline. It is coming back to the midline. It's adduction, adding. Yeah. Okay, rhomboid. rhomboids there. Oh, what I was trying to say here really quickly, looks like the same muscle, right? Rhomboid major and minor, there's no difference to us. There's a slight line of division, that's why they name them as two muscles, but really they're the rhomboids to us. They are deep to the trapezius, but superficial to the erector spinae. We have not learned about the erector spinae yet, really, but they're these long muscles running up and down your back. We will get to them eventually. We've talked about them very briefly. Okay, here's the levator scapula. So you've gone, if you're running your hand up, superiorly up the medial border of the scapula, the first thing you hit is rhomboids major, then you get to rhomboids minor, then you get to the levator scapula. It inserts on the medial border of the scapula, right, between kind of the spine of the scapula and the superior angle of the scapula. And as the name would suggest, it elevates, levator. It is an elevator of the scapula, the scapulothoracic joint. It attaches to what are called the transverse processes of C1, C2, C3, C4. It is a nasty little muscle in that it actually causes lots of problems for people. It's tiny, it gets tired, it gets irritated, and you've got nerves coming out of the side of your neck that this muscle sometimes pinches on. So it's an important muscle to know about. It's an important muscle to work. I think we can see how it elevates because it grabs onto the head just like your upper trapezius does, right? I think we might even be able to see how it downwardly rotates because, again, by grabbing onto this edge of the scapula, when it lifts, it naturally wants to lift one side up and the other side goes down. It also, very much like the trapezius, can laterally flex the head, right? This is when it's working on just unilaterally, Mr. Metrick, just one side, right? It will laterally, it could raise my shoulder, but it could also bend my head to the side. And sometimes have you guys ever had a neck ache where you try to bend your head to the side and it kind of hurts right in there? It wasn't a guarantee, but it probably was your levator scapula. That little sucker gets really annoyed. It gets really tight from, you know, when Miss Correa was taking all her notes. She's probably making a 3-ring binder. So, kind of like the guy, have you ever seen Parks and Rec, Miss Correa? Yes. Remind me of the really devoted person in there. You know, you're on top of things. I love it. It's a compliment, by the way. That's a compliment. But she's always making 3-ring binders. Anyway, so this guy can laterally flex your head, and it can help to rotate your head and neck a little bit. That one's always a little tricky, but anyway. Sorry, it can help to rotate your head and neck because it can kind of pull on these little transverse processes and help bring them back. That's hard to see, but it can. It can help rotate your neck to the same side. So, I hate to stop sharing, but I want to make sure you guys see me for a second. Let's make sure we understand what transverse processes are. All of your vertebrae have transverse processes. So, if I was a vertebrae of this skeleton, my face and nose right now would be the spinous process, these bumps sticking out of the back. My arms would be my transverse processes. This is me. And my big belly is really the belly of the vertebrae, because the vertebrae has a big solid stack that stacks onto the next vertebrae. But out the sides, it's got transverse processes and a spinous process, and those are purely to have muscles hook onto them. So if you hook muscles on these transverse processes, you tend to laterally flex stuff. If you hook stuff on the spinous processes, you tend to extend the back. You tend to do stuff like that. I just want to make sure we know what they are. And remember, out of the sides of all these vertebrae are nerve plexes coming out. Big bundles of nerve fibers coming out by these transverse processes. They're two different things, but just they're all in that area. They come out the sides of my neck. And so when people get their levator scapula tight, sometimes it pinches on these nerves in here too. But they really are on the sides of the neck here. And they go out and hook into my shoulder. And it's a tiny muscle, so it really does get irritated easily, causes people a lot of problems. Right? Yeah, who was it? Hold on, sorry. My computer's being weird. Yes, Miss Carrillo.
I remember you talking about like the Coracoid process. So processes are things that poke out?
Yeah, they are. And unfortunately, there's like 13 names for things that stick out on your body. And it doesn't really matter. They all mean like a butt. So there's processes, protuberances, trochanters, tubercles, epicondyles, condyles, all those things, these bumps that stick out, and they all stick out really for the purpose of muscles to hook onto them. Basically 100%, that's their job. But anyway, yes. So these are transverse processes. These are transverse things that stick out. You're right. And you're right, the coracoid process is one that sticks out from your scapula in front. And we're going to learn why that's so important today, actually, because we're going to learn about a muscle that hooks on there. Okay, so now you all, it's kind of cool. Now when you're running up your hand up the side of the medial border of somebody's scapula, when you grab onto it, you now know the 3 muscles that you're hitting there. We're going to find out about a 4th one you're hitting too. But there are 4 muscles there: rhomboids major, rhomboids minor, levator scapula. And it actually kind of looks like this: rhomboids major, rhomboids minor, levator scapula. Yeah? 4, 2, and the other one's about 2. So those muscles all help to kind of move your scapula around your body, right? And those muscles work oftentimes separately with the trapezius to do things, you know, to your scapula and move your scapulothoracic joint around. They don't move my arm. My arm just comes along for the ride, but they move my scapula around. Yeah? Yeah. Okay. Good. This next part is very tricky. If you can see me, this is my right scapula. We've now learned that there's these muscles there. Left scapula. I do know my left from my right. This is my left scapula. And we've learned that there's a rhomboid major hooked here, rhomboid minor hooked here, and levator scapula. Well, watch my hand here. Let's pretend this is kind of rhomboid major, right? There is also a serratus anterior hooked underneath. Do not confuse this with the subscapularis. The subscapularis is glued inside here and goes to your shoulder. This muscle is actually sharing the medial border with the rhomboid. It's going off this direction, actually, like this. So your rhomboids are here on this side and your levator scapula. And on this side, hooked to the medial border, is the serratus anterior. I'm going to show you a picture of it, but I just want to kind of explain to you where it is because it's very hard to conceptualize. Mr. Craven, please.
I think I noticed some like grooves in the posterior of the scapula. Is that like where they fit into? Like right?
Yeah, you're talking about like all these little kind of grooves?
Yeah, I kind of see them.
I've been told those are to help the muscles anchor extra well. But the rhomboids don't really attach to these, well, I guess these kind of teeth-like grooves. Is that what you mean right here a little bit?
Yeah.
Because the rhomboids go right on the edge here, basically. The rhomboids actually touch the serratus anterior on the other side. They just run in very different directions. But most of this kind of dimpling here, that really helps the infraspinatus really hook on, and the subscapularis really hook on. I don't know if that answered your question, but yeah. Thank you. All right, let's talk about the serratus anterior. Okay. Come on, little computer. Good. All right, so that's levator scapula. And it hooks onto the transverse process of C1, C2, C3, C4, and goes down to this medial border, but up high. It is palpatable. You can rub it, but it is deep, deep to the trapezius. I actually like to come in from the front sometimes and kind of wrap underneath the trapezius a little bit and try to get to it. That's one of the ways I prefer to get to it. They're kind of showing you the trapezius here. If you come down from the top, you kind of run into it, but if you come under from the side and stuff, you can get to this muscle easier. All right. Then there's this muscle. This is very hard to visualize, but this is the Serratus Anterior. Serratus means saw-like. It's called the saw-like muscle because these little things pushing out here look like little teeth. They sneak out from underneath the latissimus dorsi. The latissimus dorsi is over here, and they sneak out under here. You'll see these in bodybuilders especially when they lift up their arm. They look like finger-like projections. Not to be confused with their abs, which also look like finger-like projections in some ways, but these actually look like fingers sneaking out from underneath your axillary region. And they are saw-like projections, and so they are called serratus. It's serratus, but it's serratus. It's the saw-like muscle, Serratus Anterior. You have, by the way, anytime you hear something called anterior, it implies you have a posterior one. And you do. They do something very different. We're not going to worry about it right now. We are going to get to it, but I just want to let you know, if you've got something called, well, you guys already know this, you have a supraspinatus, well, you have an infraspinatus. We tend to not use those terms unless we have something else that we're trying to differentiate it from. Miss Everson, please.
Sorry, I'm skipping a little bit ahead here, but why does it say that it's on the external surface of the upper 8 or 9 ribs?
So, it's on the external surface because they just mean it's on the outside of your ribs, not the inside, because you actually can have muscles on the inside of your ribs. Why does it say 8 or 9?
Yeah.
Why do I weigh 230 pounds and have hair on my body and look the way I do, and why are you like half that size?
Do we have less ribs?
No, I'm sorry. Because, not a size difference, because everybody's different. And they really are different. Just like we all look really different, muscles are not exact. And on some people, nothing to do with size, by the way. You might have it attached to 9 ribs, I only have it attached to 8. But the point is we are just all slightly genetically different. Yeah, sorry, that was a bad way of making that point. I was just trying to be like, we're all different. But we are. So you really could have it attached to 9. You're pretty cool. You probably do have it attached to 9 ribs. I'm just kind of an 8 rib kind of serratus guy. I'm average, you know? Anyway, we just noticed there are some small variations. There are some people that even have muscles that other people don't have. Not big ones. Not like, you know, but some people even have these rare muscles that only like, 10% of the population have. And with Serratus Anterior, some Serratus Anteriors attached to the first 8 ribs, some attached to the first 9 ribs. And by the way, guys, we count ribs the same way we count thoracic vertebrae. T1 is attached to your first rib. T2 is attached to your second rib. T3 is attached to your third rib. T12 is attached to your 12th rib. So these are attached. These actually insert into ribs 1 through 8 or 1 through 9, depending on if you're Miss Everson or Mr. Tapscott, right? Cool. And we have no idea why that difference occurs, but it doesn't seem to matter. So anyway, that's that. That was the origin. The insertion is on the medial border of the scapula. So this thing really goes underneath the scapula, comes around from my ribs, goes underneath my scapula. It doesn't attach to the back of the scapula. It actually goes underneath the scapula and gets to my medial border and hooks there from the front. So if I have a muscle coming from my ribs going back to my scapula and it contracts, what's it going to do to my scapula? Yeah, I think you're right. What do you call that, Miss Everson?
Medial rotation, but I don't think that's right.
So what if it's not right, but your thinking is right? Do you know what it might be called if it's moving away from the midline, not towards the midline, away from it?
Abduction.
Abduction, yeah. Abduction of the medial of the scapulothoracic joint. Also, by the way, this muscle moves a little bit downhill. This muscle moves a little bit downhill, and so it would also help to depress. Yeah. And by the way, it does something else that's really interesting. It helps to hold the scapula against the ribs. And that might not seem like a big deal, but remember we have this crane, the glenohumeral joint, moving around on the scapular crane. Well, if you're picking something up with a crane, you don't want the bottom of the crane moving, do you? While you're picking stuff up. No, you don't. So when you guys are typing at your keyboards or you're writing, your arm would be all over the place if your scapula didn't lock down. So your body actually locks your scapula down to your rib cage when you do really precise stuff with your fingers. Like type, like write, like pick your nose. If it didn't lock down, you might kill yourself. Like, who knows? Pretty dangerous. All right? So it helps to lock down the scapula to the back, helps to stabilize it. And that's actually extremely important, even though no movement's occurring. So, what muscle does this muscle argue with? Because these are almost the exact opposite. Yes, Miss Everson.
The rhomboids.
She's 100% right, everybody. And this is a super important massage fact. All right? Some advanced kinesiologists call this the rhomboserratus kind of muscle group, because they almost see these as one. I've got these muscles around a rib cage here. Boom, boom, boom. Can't wait to go to the other room and get bigger stuff here. But I've got these muscles around this rib cage here, and I've got ones back here called the rhomboids that are hooked to this medial border. I've got the Serratus Anterior hooked to medial border but in front. And the rhomboids run up and the Serratus Interior runs down. So I've literally got this muscle that pulls my shoulder back and up, and I've got this muscle that pulls, my scapulothoracic joint, and a muscle that pulls my scapulothoracic joint down and forward. Elevate and adduct, depress and abduct. Elevate and retract, depress and protract. Yes, Miss Carrillo.
Would that make them antagonists to each other?
Yes. Yes. And here's why that is really important. Anybody can rub a back. Remember, we're trying to get very good at it. And one of the things we do is we're more accurate, and so we can get more work done faster. But the other thing is we understand arguments. And I've used this example before, but I want to use it one more time. A lot of you guys don't know this, but Miss Carrillo and I fight a lot. We just don't agree on anything. And basically, she's extremely rude to me. And even after I calm down, she's still rude to me, which gets me riled up again, and I start yelling again. And the only way to really fix the fight between both of us is to get us to both play nice together at the same time. Otherwise, the other person's like, I'm not touching you, I'm not touching you, I'm not bothering you, right? So regular massage therapists go and they figure out you got tension in your back and they rub the rhomboids. But the rhomboids are usually arguing with the Serratus Anterior and they don't ever fix that problem. And so the person walks out feeling good, but they start feeling bad and tight again hours later, maybe a day later. And you'll actually hear these comments after you graduate from this school. You'll have people come back and they'll be like, I don't know what it is, but when I go see Miss Carrillo, like, I feel good for like a week afterwards. And I go see this other therapist, Henry, and there's no Henrys in our class, I hope. Henry, he's our pretend guy who went to another school. Henry, when he works on me, he basically does the same stuff. I mean, it feels kind of the same, but I only stay loose for like a day. And that's because Miss Carrillo stops the arguments. She doesn't just focus on the muscle that's obvious, she focuses on the muscle that might be fighting with that muscle, and she stops the entire argument. Yeah, so super duper important. These guys literally kiss. They are literally connected. Some people even refer to them as the same muscle because the scapula is just hooked between them. It's caught between this tug of war between these two things. And really, you could actually technically lift a scapula up, and this is what you'd see. Serratus Anterior pulling stuff to the front, rhomboids pulling stuff to the back. The job of these two muscles is to move this thing back and forth around my egg. That's what their job is. Yes. Mr. Craven.
I think I kind of figured this out while you were talking, but like, do we always have, like, especially with like diagonals, like, do we always have like an antagonist? Like, are there any muscles that we have that don't have something that like does the equal thing in the opposite way?
Yeah, I think essentially you're right. I by the way, I can't review every muscle in my head. I'm not that fast, but I think you're absolutely right. There has to be an antagonist of every single muscle. Otherwise, stupid, simple example, but I would never be able to get this arm out of this position if I didn't have an antagonist, right? So I have to have something on the opposite side that gets it back out again. And so I think everything in your body, essentially, whether it's diagonal or not, if it has something moving it some way, it's got something else that can fight with it to move back. And by the way, they're not always fighting. Sometimes it just moves it one way and moves it back. But if there is a struggle, and the reason struggles occur is because your body tries to stay in good posture, but your shoulders are really tight, but it tries to pull them back forward to kind of even you out because it knows this isn't normal. Your subconscious mind knows the posture you're supposed to have. And so it'll start fighting with that. And that's why you want to get rid of tension on both sides. So anyway, short answer, yes. I'm sure. I can't imagine a situation where that's not true. And there could be multiple ones too, but yeah. Ms. Everson.
So, the Teres Major and Minor go from the C7 to the T5. How do you stop the argument then? Do you like start those or
Rhomboids, wait, rhomboids major and minor?
Yeah.
Okay, you said Teres Major minor.
Do you stop the argument by like working at the origin, going over to the medial border of the scapula, and then like putting the arm behind and reaching underneath to get to the
Sure, Serratus Anterior?
Serratus Interior?
Yeah,
and then
sorry,
do
go
you
ahead.
go to insertion or insertion as well, like behind there? And then
Yeah.
try to move under the scapula as much as possible to the ribs to stop them?
Yeah, I mean, yeah, that was actually great what you said. I don't even really have a lot to add to it. But essentially, I was just trying to point out that you should rub the rhomboids and the serratus anterior. You got very detailed about how to do that. That's one of the reasons, you're right, I like grabbing on to the medial border of the scapula, because that way I'm hitting the insertion of the serratus anterior and all the rhomboids, and I'm stretching the rhomboids. And then essentially, if you lift somebody's arm up and you rub their ribs here, you're hitting serratus anterior. Rub the first 8 or 9 ribs right here, right? And just be careful, everybody, because you're right next to breast tissue right here. You're trying to rub the ribs. And the serratus anterior is kind of hard to feel on the ribs. It just feels like meatier ribs. It feels like extra delicious ribs, right? It feels like meatier ribs, and you can actually feel like there's a little bit more meat on these ribs here than there is if you go down lower. Go down lower, it feels like rib bones. Go up higher, oh, meat on rib bones. That's your serratus anterior.
We could really only touch like the first like centimeter of the origin, like the origin of the serratus anterior, can't we? Because like our scapula only goes up so far, and we can't really.
Sure, although it lifts up, you probably could go underneath quite a bit. But if you look at the origin here on the slide here, I'll show you. You can. I mean, you can't. You're right. It's hard to hit the entire muscle. She's 100% right. You can almost do it, but the origin is just. The origin is really just sticking to these first ribs. It's not glued to them all the way back. I'll show you a slide. It'll make better sense.
But it goes under the scapula, and we can't really like massage under the scapula unless we like push on it.
Yeah, but you kind of can. I think you really kind of could. You can put your flat hand under the axillary region. You can kind of massage underneath it. I mean, just quite a degree. Yeah. But you're right, at some point you run into some limitation, which is why you grab onto the medial border on the other side. And Ms. Everson, it's hard to do on yourself because your scapula is tightening up while you do it. Does that make sense? I hope. And here, hold on, let me share this thing here really quick. Dun dun dun, I know it's going to work this time, come on. I don't know that actually. Yeah, jeez. Okay. We're going to try one more time. We really are. Seems to take twice sometimes. All right, come on. Okay. So, the serratus anterior actually attaches to these little spots on the ribs, right here where it's gray. And those are very accessible to rub. So you can get every bit of origin And you can get every bit of insertion because you can rub the medial border and put your hand underneath the whole thing. So that's kind of cool. And then you can rub most of the muscle, not all of it. You're absolutely right, Ms. Everson. There are some things that just, you're going to run into some stuff, but you can rub quite a bit of it. And here's an example of somebody working on the serratus anterior. Yes, Mr. Overman, please.
I'm just wondering, can we get to more of it by abducting and adducting the scapula?
Yeah, I would argue that what you want to do is adduct the scapula. That's kind of what this lady's doing by pushing. Well, she's using this because the person pushing against her lets her feel the serratus anterior. But if you push as you push the shoulder blades back, you adduct them, get them closer to the spine, you expose more of the serratus anterior. You also put it into a stretch at the same time, and massaging muscles while they're in a stretch is very effective. So yes. And look, what this person's doing is kind of both. They're rubbing the origins here, and they're hitting the insertions just like we talked about here. And by the way, this has nothing to do with what I'm talking about, but we discussed muscles that Miss Everson was asking why 8 or 9 ribs. This is a muscle called the sternalis, which only some of us have. It's in your book too. It's called the sternalis. It's a tiny little teeny tiny muscle that we don't really know what it's left over from or what it does. That's right around your sternum. It's so tiny it's very hard to feel. I've never worked on somebody and been like, oh, that's your sternalis. But some people have this tiny little muscle fiber here and other people don't. Just another example of something kind of weird. Kind of weird little variations. And what we're trying to show you here is just the fact that the serratus anterior runs a little bit under breast tissue. So one of the best ways to work on it with a female client is sideline. Because what happened, I'm sorry to be graphic, but it's important. When she lies sideline, gravity pulls her breast out of your way. And now I've got more rib exposed. So that's a great way to work on that. It is okay to ask your client to hold her breast through the sheet out of your way too. That's fine too. It's just that clients don't usually like doing anything. They'd like to lay there and be lazy. And that's kind of what they're paying us for. But I'm just saying that's an option. That's an option. It is not an option for us to touch breast tissue. That's actually against our license. So, you got that. So now we know 4 muscles that insert, and there's only going to be 4, that insert into the medial border of the scapula, right? Rhomboids major, rhomboids minor, levator scapula, and serratus anterior. What was that, Mr. Craven? Watching you do signs over there? And
Well, in one of the pictures, it just looks like he's like karate chopping
the breast. Yes. Well, he is doing something really smart, by the way. Anytime that I'm near breast or glutes and all that kind of stuff, whack it. No, but I don't want to use a flat hand because a flat hand feels gropey. A karate chop does not feel gropey. It feels like I'm saying this is where I'm holding the sheet. And so the karate chop, I don't know exactly how he's using it there, but the karate chop actually is a kind of a good way to kind of hold stuff down because it doesn't feel like I'm touching you. It feels like I'm like, that's where we stop. Yes. I like that though. Karate chop. Okay. Last but not least, this is the serratus anterior's friend. This is the serratus anterior's friend. It's the pectoralis minor. Remember, it has nothing to do with pectoralis major, basically. It's going diagonal. It hooks to the scapula in a very weird way that we always forget about. Even massage therapists forget about this. On the coracoid process, you have a beak-like projection on the front of the scapula. Even though your scapula is in back, it sneaks out over this egg. See how this looks like an egg? We always think of it as a square shoulder, but it looks like an egg. And it attaches to ribs 3, 4, and 5. And anytime I talk about it, you'll see me do this. I love this. This is our gang sign, okay? And I love this for a lot of reasons, by the way. It's about this size. This is going for my coracoid process right now to ribs 3, 4, and 5. So it tells me how many ribs it attaches to. It tells me the rib number it starts with, and it gives me the rough size and the angle. Yo. Right? Pectoralis minor. Blood in, blood out, man. All right? Let's go. So, ribs 3, 4, 5. It runs at this angle, and it hooks to the scapula. It's actually in back. So can we see that if it contracted, I think as Miss Carrillo already figured out, it would protract or abduct and depress, exactly like the Serratus Anterior, which also protracts, abducts, right? So in a way, you've got these muscles in front, and because they're in front, they pull you in front. So Pec Minor and Serratus Anterior protract or abduct my scapula. They also run downhill, so they depress it. Rhomboids and your middle and upper trapezius pull me back and up. Down, back. Front and down, back and up. These muscles work against each other. This is why when somebody has tight shoulders, really good massage therapists don't just rub their rhomboids in their traps. And there are a lot of therapists out there that just, that's what they do. Oh, they're tight. I spent the whole time on that. Great. I really wish you would have hit Pec Minor. This is very accessible. You can hit this. It feels amazing. And so you hit Pec Minor. So you'll always see me, like when I'm rubbing somebody's shoulders, I reach up underneath their collarbone and kind of cut down across here to start to loosen up the Pec Minor. Because that's fighting with the stuff in back, and that gets tight too. And your body uses all these muscles even when it's not fighting to what? To lock the scapula down. So when I'm doing really precise stuff with my fingers, usually Pec Minor engages, Serratus Anterior engages, rhomboids engage in back, and sometimes trapezius engages in back to kind of fight over the scapula to keep it from moving anywhere. And it sucks the scapula down to your rib cage, because we all know it can be lifted off, right? It sucks it down to your rib cage and keeps it locked in there. Well, if I work at a computer 8 hours a day, my scapula's been locked down 8 hours a day. And that's where a lot of normal tension that we see in this society has to come from. So honestly, this is probably one of the most important muscle associations we're going to teach you. There are many other exciting ones, don't get me wrong. But this is a major one for people in our society. They all have tight shoulders, and there usually seems to be stuff going on between the rhomboids and the trapezius and back, and sometimes the levator scapula and back, and the serratus anterior and the pec minor in front. All of those attached to the scapula. All of those move your scapulothoracic joint around. Yeah? Boom. Pectoralis minor. Very accessible. Here's another really interesting thing about the pectoralis minor. There is a nerve called the brachial plexus. Since it has the word brachial in it, where do we think that nerve goes to? Your arm. Yep. And that nerve is coming out the side of your neck, and it goes underneath your pectoralis minor along with arteries and veins. They always like to travel together. And it can get pinched there. And has any of you heard of thoracic outlet syndrome? Okay. Well, thoracic outlet syndrome is a pinching of the brachial plexus. And it can be pinched actually in several places. But this is one of the common pinching places because when this pectoralis minor gets tight, it pinches on the brachial plexus. And people have symptoms like weakness in the arm, tingling in the arm, coldness in the arm because it's stopping blood flow from going there too. Those are very typical symptoms. That does not mean everybody with those symptoms has this problem, but it is a very good sign of it. It's very common when you see tight shoulders that people also are like, yeah, my shoulders are so tight that I'm kind of almost getting tingling in my arms. They could easily have their brachial plexus pinched at the pectoralis minor, and we call that thoracic outlet syndrome, the thing coming out from the thoracic region, and it's the brachial plexus being pinched. Yes, Ms. Clayton, please.
What is the best test to show that? Because I think I have that because my thumb is numb and I'm in pain all the time. What's the best test? Is it like a CAT scan?
Yeah, I mean, I guess. I would guess you'd have to have a CAT scan to figure that out. There actually is some nerve tests they can do too, Ms. Clayton. And what they do is they essentially prick you with needles in the right spots, and they make sure that those nerves are conducting electricity like they should, really. And they can narrow it down to the exact nerve and figure it out that way. And if for example, the brachial plexus is working great here, but once you cross underneath that muscle, it's not working so great, then you can be like, it's probably that muscle. The problem is it could be a lot of other things.
Yeah, okay.
And so,
Right,
yeah.
thanks.
The nice thing about massage, though, by the way, Miss Clayton's got a very common symptom. You will hear this a lot. And a lot of people in massage will be like, well, can you be sure it's that? No, I can't. I'm not licensed to be sure it's that. I'm not actually allowed to diagnose. I'm not sure it's that. But the nice thing about massage is we'll rub you, and if it gets better, we're probably right, and who cares? It got better. And if we're wrong, that's fine too, because we didn't hurt anything. Whereas you go and get surgery and they're wrong, it causes problems. So in massage, I often tell people, I have no idea. I've got a good 3 guesses, and we're going to work on those 3 guesses, and we're going to see what happens. You know, and I always tell them, they're like, well, what happens if it doesn't work? You're out $50. I'm very honest with them, but you still got a massage. It still felt amazing. Still was not a bad thing. Miss Everson.
So to work out the pectoralis minor, would you like elevate and depress the shoulder, but like rub it when it's elevated since it's stretched?
Yeah, and by the way, you don't have to rub muscles in a stretch. It's just a very effective way to rub them. But absolutely, you could do that. You can also pin it. We call this pin and stretching, where I actually poke right into the muscle, and then I elevate and depress you because it pulls the muscle underneath my fingers. Yes, it's very powerful.
Yeah, I felt that.
Yeah. So I love pin and stretching. I love to like lock something down and then move the thing that it's supposed to move, and it pulls the muscle underneath my fingertips. Very effective. Good, really good. Okay, one last teeny tiny muscle that they just threw in this section. I'm sorry, it's a lot of muscles. This one is not actually attached to the scapula, but it affects the scapulothoracic joint. It's a muscle you can all easily palpate on yourselves. It's called the subclavius. Remember this, your clavicle? It is a tiny muscle right underneath your clavicle. Now, if you're right underneath your clavicle right now, you might be able to feel it, but the problem is the pectoralis major also inserts up here. And so you have to kind of go through the pectoralis major. But this is one of the reasons I trace underneath somebody's clavicle, because this muscle kind of goes from my sternum over here to my clavicle, and it helps depress my clavicle. It says it helps to elevate the first rib during breathing. I'm not sure I believe that. But it helps depress the clavicle. It helps pull this down and stabilize this thing. And I'll often trace under here because I care about loosening up pectoralis major, I care about the minor over here, and I care about the subclavius. So don't be afraid to literally scrape inferiorly underneath somebody's clavicle. It feels good, and you should be doing it on everybody, basically. I mean, not every single last person. Somebody might have come in and have you work on their feet only, but it should be part of your routine, if that makes sense. And that's called the subclavius, the muscle under the clavicle. That's literally what it's named. It's hooked to the first rib over here and inserts underneath inferior surface of the middle 1/3 of the clavicle. It just goes underneath here. That part you can actually feel a little bit. If you go in the middle of your clavicle and push up underneath it, you'll feel this little thing. You'll be like, whoa, that's your subclavius. But I'm actually under my clavicle coming up. I think that's it, by the way. I hope that's it. Good. That was a lot of stuff there. So I'm actually, for that one, actually coming up underneath my clavicle right there. Boom. Underneath here. And if you rub under there, you'll feel some crazy stuff going on. That's your subclavius. That is a lot of muscles. I think you'll agree. So, most important thing, just want to make sure I'm telling you this right. Yeah. The most important thing now is that we know 1, 2, 3, 4, 5. We know about 6 muscles that are responsible for moving the base of the crane around, the scapulothoracic joint around. We've learned about the trapezius. The trapezius most definitely hooks your scapula onto your thoracic region and your head and all sorts of stuff, but it hooks your scapular body. That's trapezius. We learned about rhomboids major, rhomboids minor, and levator scapula. So we learned about 4 muscles in back that hook your scapula to your body and in general pull it back. We've also learned about 2 muscles in front, Serratus Anterior and Pec Minor, ribs 3, 4, 5, Pec Minor, that pull your scapula forward and down. That's 5 muscles that are responsible for moving your scapula around your body. Once it gets it to the right place, then all these other muscles can move your glenohumeral joint. These are muscles that move your scapulothoracic joint. And this subclavius kind of falls in that category that it helps pull down the collarbone, and the collarbone is hooked to your scapula, but still, it's not like the other ones. So, we've got two muscles in front, Serratus Anterior, right, and Pec Minor, that kind of pull you in front and down. We've got the rhomboids that pull you back, and the levator scapula that pulls you up. And we've got the trapezius back there that does all sorts of stuff. Upper fibers lift you up, lower fibers pull you down, they all pull you back, that kind of stuff. And that's how they move your scapula around this egg, because we've got to move it from front to back and back again, and we need to be able to move it up and down and rotate it. And all these muscles do that. So if you think that there is a problem with somebody having scapular tension, which is what most people mean when they say they have shoulder tension, they don't actually mean their deltoid's tight, right? They mean their scapulothoracic joint is tight, which isn't really a joint, but that's what they mean. That's what they're thinking of, right? And they're like, oh, my traps are tight. Maybe they are. I totally believe that. But then your rhomboids are probably tight too. And I better look at the levator scapula. And then if I'm going to look at all those, then I better look at the Serratus Anterior and the Pec Minor. Those are the 5 muscles that have an awful lot to do with what people call shoulder tension, which is really scapulothoracic tension. Boom. Questions, thoughts, comments on that? Anybody? Please, Miss Everson, please.
I have a friend that has like a really bad posture. He leans forward quite a bit, and so his back's already kind of doing the
hump thing?
Yeah, the hump thing. How would you go about like bringing that back?
Wow.
Because his like head is going forward, his shoulders are going forward.
Yeah.
So everything's tight. Like, would you loosen the chest more?
Yeah.
So that he.
Yeah, that's exactly right. You want to smear him out in front. And so you're right. You want to actually open up his chest, open up his rib cage, open up his neck. Yeah. It's probably not the muscle. The muscles in back. I'm sorry, I'm getting weird feedback. Hold on. The muscles in back are probably really sore and tired and tight on him, because this is not a very comfortable position for them, right? And they're working extra hard, and so that's probably the muscles he or she complains about. And you should rub those out of courtesy of getting rid of the aches and pains of them. But the problem is shortening in front. The problem is actually a shortening in front of muscles. Those need to be stretched out and open up. That's the symptom. The symptom is the pain back here, but that's actually not the problem. The problem's in front, and this is very typical in massage and life.
So butterflies like help strengthen those.
You're getting very strange feedback.
Oh, sorry.
It's okay. So butterfly movements might strengthen those muscles in front too, yes. But I'm not worried about them necessarily being weak. I'm worried about them being shortened. They need to be... Butterflies where you lay on something and let the dumbbells actually open you up would be fantastic. Fantastic. And hyperextensions where you're leaning back and really letting your chest open up would be fantastic. And you can do some of that on the table for them. You can put the arm out on the table and open up their chest. Yeah. Absolutely. Mrs. Savarino, please.
This is kind of off topic, but Ms. Everson kind of reminded me about this. My mom is kind of recovering from breast cancer. She just got her lymph nodes removed, and she said that she can't like lift her shoulder, but her skin's kind of thin too. So I was wondering, is there anything I can massage? Like she has to do something to where like when she can lift her shoulder, she can start another treatment. So is there something I can do? Where should I massage around like the lymph nodes in her auxiliary portion? Like, is there anything I can do? And is there like a protocol for like thin skin, like cancer, like chemotherapy?
Oh, gotcha. Okay. Is she done with the chemo?
Yeah, she's done.
Okay. Yeah, so the thin skin part, you use more oil. And it's the only time you're ever going to hear me, well, 2 times you'll hear me say use more oil, when you have a really hairy client and when you have somebody with thin skin. For whatever reason. Because you don't want to tear the skin, right? It's just thinner. So more oil helps make it more comfortable for her. It's just less unpleasant. Then a really simple protocol is to first start to put her through range of motion. Are you saying, by the way, her glenohumeral joint's not going up?
Yeah,
Or
yeah.
okay,
So like she can't lift her shoulder up.
okay. And so first thing is, can you lift her shoulder up?
I haven't tried. I was
Okay.
just getting like mess with anything. I was like, let me ask and then I'll get back with you.
All right. So first, so we want to find out. There's two reasons why somebody can't lift their shoulder up. There's probably 5,000 reasons why, but there's two main reasons why they can't lift their shoulder up, and that is one is their muscle's not working, right? So maybe the nerves to the muscle aren't working, whatever, and she physically can't lift it up. But if that was the case, you'd still be able to lift up because the joint would be working. All right? And so that's a different problem. I doubt that is her problem. I suspect you'll be able to lift the arm up. Well, I suspect you won't be able to lift the arm up. I'm sorry, that's what I wanted to say. If you can lift the arm up and she can't, it tells you the joint's working and her muscles aren't working. But I suspect it's more that her shoulder's kind of frozen now. And they literally call it frozen shoulder. And that, what you do is you literally lift it up as much as it'll go gently, and you start massaging the muscles that are attached between the glenohumeral joint, between the scapula and the humerus, and you start massaging them to try to open that up, and you keep moving it more and more each session, and you're slowly stretching it and freeing up the frozen shoulder.
Okay.
That's the idea. And by the way, that's why I talk so much in this class about like what muscles go between these two places, what muscles affect this joint. Because usually when there's joint problems, the first thing you do is just massage every single muscle that could have something to do with that joint. So since it's a glenohumeral problem, you'd hit deltoids for sure. You'd hit all the rotator cuff muscles for sure. That would be like a good place to start. Yeah.
Okay. Thank you.
No, thank you. It's a really good question. Miss Clayton, please.
Sorry.
Oh, that was a leftover?
No,
Oh.
so back on, what Mrs. Everson was talking about regarding the guy that leans forward.
Yeah.
And you were talking about doing the stretching, the butterfly stretching.
Mhm.
Is it also good to work the back muscles so they get stronger? Or
Yes.
Is that not?
No, that would be it's just that we're not really physical therapists, so, but yes, it would help, absolutely, to strengthen up the backside muscles, absolutely would help. Yep. And physical therapy and massage therapy go together hand in glove. Yeah, for that reason, really. Miss Carrillo, please.
I feel kind of silly asking this, so.
No.
You said 5 muscles move the scapula around, and I listed like 6.
Oh, I can believe that. I can believe that you're right and I'm wrong.
The trapezius, the rhomboid major, minor, Levator Scapula wouldn't do that.
Levator Scapula moves what do you mean moves it around? Just moves the scapulothoracic joint?
Oh yeah, I'm so sorry, the scapula moves it around. I'm so sorry, my notes, I was just reading.
Don't be.
Just moving it around like this, I'm so sorry.
And by the way, when I said, in this case, I just meant it moves it around your body. I didn't mean I just meant these muscles tend to move that sucker around somewhere. Yeah.
Yeah, okay.
And then on top of that, you got, keep going, yeah.
Yeah, so it was the traps, the rhombs, Levator Scapula, Serratus Anterior, and Pectoralis Minor.
Yep. And then you're right, so you caught a whole bunch. And then trapezius too. So it's 7 actually.
There's
Yeah.
7? What? 1, 2, 3, 4, 5, 6. What am I missing?
Well, do you count the rhomboids as 2 muscles or 1?
As 2, so the trapezius, rhomboid major, minor, Levator Scapula, Serratus Interior, and Pectoralis Minor.
Pectoralis minor. Yeah, you're right. I'm sorry. I forgot that we'd said a trapezius before. Yeah. I don't memorize like the numbers of the stuff, but yeah. So I'm messing you up. It's 6 then.
Thank you.
Sorry about that. Mr. Richards, please talk to me.
So if someone had a knot under their shoulder, under their scapula, would that be the rhomboids or the serratus interior that's the problem?
Where are you finding this knot?
Do you know, underneath the scapula?
You're underneath the scapula. And what does that mean? I mean, we've now got all these layers and everything. So if you're you're underneath the scapula, not between the scapula and the spine, right? You're underneath the scapula?
The medial part of it.
Okay. Well, if it's underneath the scapula, then it's got to either be the serratus anterior or it could be the subscapularis. That's underneath the scapula too. But the rhomboids don't go underneath the scapula, so it couldn't be them. Did that answer your question?
But that attaches from the scapula to the spine, right? The rhomboids.
Right, but they're not under the scapula. There's no scapula on top of them. Does that make sense?
So that's what I mean. You know the space between the scapula and the spine.
Oh.
There's problems.
Okay, but
not literally underneath the scapula, but on that medial border.
Okay, that's.
Could be 3 different, right?
So that's totally different. So you're talking about in the thoracic region between the medial border of the scapula and the spinous processes of your thoracic region, essentially, right? And that very definitely could be the rhomboids and would not be the serratus anterior. The rhomboids, sir, if it helps, the rhomboids run from your spine over to your scapula, okay? And then we can't see it, but underneath my scapula, the serratus anterior picks up and keeps running to the front. So I can't put my hand underneath the scapula. Let me do it with this one. Hold on. Let's see. There we go. Sorry, it's this side. This is really how this is my rhomboids here. I have to hold this with a finger, but my rhomboids only go to here. They stop at the medial border, and they hook you to the spine. The serratus is actually underneath, kissing them, going to the front. And so these guys literally go up and back, and the serratus pulls down in front. And so the serratus is actually underneath the scapula. You can actually lift up, and there's the serratus there, and go into your ribs. The rhomboids are never underneath the scapula. They'll pull it in here, they'll let it out here, but they're never underneath it. Does that make sense?
Yeah, because I have obviously now and again I get like a knot under there.
Sure.
So I was wondering, which one's probably doing it.
You're right. But do you get a knot under your scapula or just between your scapula? Between your shoulder blades.
Yes, that's it.
So between your shoulder blades is probably the rhomboids or middle trapezius, right?
Yeah, I was thinking that.
Yeah.
Thank you.
Thank you. Yeah. Miss Clayton, yes. By the way, guys, I'm releasing your homework as we speak. That's why I keep looking away. But keep talking.
That question comes up a lot. How do you get rid of a knot? Is the best thing to get rid of a knot cross fiber work?
Okay. So you guys are going to ask lots of questions like this, and you should. Keep asking them. I will give you my opinion. The reason it's an opinion is there are not a lot of studies done on massage therapy because places like pharmaceutical companies and medical companies don't want to do research on massage therapy. It doesn't make them any money. And so there's loads of research on surgeries and drugs and all sorts of stuff. What we have in massage therapy is usually practical experience of massage therapists. So I feel like I'm in a good place to answer that question. I've been doing massage a lot, but there will be varying opinions about this sort of thing, if that makes sense. I don't like cross-fiber friction except for breaking up scar tissue. I think it's aggressive. I think it's painful. I think it irritates the muscle, and I'm not sure it really breaks up a knot. We all have to remember, too, there is no such thing as a knot. They don't even exactly know what knots are. We do know that muscles seem to get caught in contractions, and we think that's what a knot is. And when I first got out of school, it was like knots, trigger points, all that kind of stuff. I later, for me personally, kind of got away from that. I looked at big structural stuff. Because I found that releasing a single knot might bring some people a little bit of relief, but it didn't fix the problem. If a problem is just a knot, like really just a knot in the muscle, it's going to rub out anyway. And I just like to go with the fibers and stretch it out and stretch and stretch and stretch, and I find that that helps. But I'm not a big cross-fiber friction fan. I think you're strumming against fibers, and I could see why it might break that area up. I'm not saying it's wrong, but it's a very aggressive approach, and I think there's other ones that I like better. I like to just apply a boatload of pressure on that thing and steamroller over it. And if that doesn't work, put it in a stretch and steamroller over it. So that's me. I only use cross-fiber friction for breaking up scar tissue. Yeah. That doesn't mean it's wrong, by the way, to do it. You should try it.
Well,
And
like what you're saying makes sense to kind of just force it to stretch and then keep pushing it in the
Yeah.
direction that the fibers go.
And other really, really good therapists, like structural therapists that do use cross-fiber friction, they tell me the same thing, basically. They're using cross-fiber friction because they're looking for scar adhesions in your body, places where stuff is really stuck and they're trying to break it up. Yeah. Miss Everson, please.
Is our homework the 17 test, TD2, shoulder, arm, rhomboid, levator, scapula, etc.?
Most definitely, and there's an 18, there's an 18 matching on the skeletal chapter, chapter 19 in your massage therapy book, the skeletal chapter. So there should be a 17 and an 18.
Okay.
A 37-point assignment and a 5-point assignment.
And that's the back of the book that I mentioned.
That's the other book, chapter 19. Yes, it's the back of the chapter. Is that what you meant?
Yeah.
Yeah. And you should all be able to see them now. I think I've got them all released. Day 17 test on what we just went over, and day 18 matching from the back of the chapter 19 in your book on the skeletal system. Is there anybody who can't see that since we're all together right now? Nobody? Good. And you've got 20 minutes to start looking at it right now if you want. You have to stay here either way, so please do. All right? I'll be in and out to check on you too. I got to go check on something, but I'll be back.